Hello, everyone. Welcome to our invitation medical reality talk show. We are coming to you live from Guangzhou, China, and it was an amazing time. This is just a broadcast, so welcome as you join us today. Now the floor to do our opening prayer.
Let us bow. Our Lord and our Redeemer, we thank you for this time. Thank you for bringing us together. We thank you, Lord, for this day that you have made. We say thank you, Lord, for your grace and mercy upon us. Father, as we have come, oh Lord, to learn, we pray that you take control. We pray that you lead us. We pray that you carry us through. We pray, oh God, that you open our mind, oh Lord, to whatsoever we are about to learn. We ask, oh God, that your will be done. We pray for stable internet, Lord. And we pray that you, oh God, will take all the glory now and forevermore. In Jesus' mighty name we pray. Amen. Yes.
Okay, so you're welcome. I just want to introduce briefly. Welcome all of you. First of all, let me introduce our team. So I'm here with Naomi Flomo, who is my co-host today. She is she's joining me from Black Rivers, St. Elizabeth in Jamaica, and she is the prayer and worship coordinator at ICMFEL. And we have Dr. Elinor Anante, the administrator. She will be joining us from Accra, Ghana. So she just will be on the team today. But we also have Mugada Flomo here from China. She is also on our team. And Dr. Mambulu Faustin is member of the team, and he's from Congo. He's joining from Guangzhou, China. And Dr. Victoria is from Canada, but she also joining us from Guangzhou. So let me go on to introduce our special guest today, our panelists. So our first guest is Pauline S. Johnson, and I'm going to be introducing her briefly. Guess you can see the screen? So it's my honor to introduce our first guest. Ms. Pauline S. Johnson is a first-year PhD candidate in public health at the Central South University in China. She also holds a master's degree in public health. So before her studies in China, she worked with a couple of non-profit organizations in Liberia, the Plan International Liberia, Action Aid Liberia, and Association of Medical Professionals of Liberia. And she is passionate about human development and humanitarian work. And she's also interested in improving the health and well-being of people with disability. So her research focus is on mental health and the quality of life of people living with HIV/AIDS. She believes if young healthcare professionals can work together and direct research on the most pressing issues affecting healthcare, they can help make better health delivery system for all people, especially those in low and middle income countries. So we want to welcome Madam Johnson, Madam Pauline Johnson. We want to welcome Madam Johnson. I will now ask my co-host to introduce our second guest.
speaker, Dr. Momo Tekli, is the technical lead to the Director General Officer of the National Public Health Institute of Liberia, ICMFEL, and Dr. Tekli is also a lecturer at the Graduate School of Public Health of the University of Liberia, and at ICMFEL, he provides technical support to the Division of Infectious Diseases and Epidemiology in disease detection, prevention, investigation, and response. He is passionate about medical and public health research, and currently he serves as the clinical research associate on a malaria transmission vaccine study, and that was conducted in Bone County, Liberia. Dr. Tekli earned an MBBS degree from the St. George University in China and a Master of Science degree in infectious diseases from the University of Kent in the UK. So Dr. Twackley, you are welcome once again.
Thank you.
Thank you, Dean Flomo, for that introduction. I'm going to go ahead and introduce our next guest on the panel today. She also hails from Liberia, specifically Bone County, and she moved to the US in 2017. She has a BS degree in nursing from the Cottington University, and she currently a registered nurse in the United States of America. She has a Master of Science degree in Environmental Science and from one of the prestigious university here in China. She worked as a consultant with the Infrastructure and Implementation Unit at the Ministry of Public Work in Liberia after earning her master's degree in China. She's currently a candidate for a Master of Science degree in nursing with focus on geriatric in primary care. She loves working with everyone, but most especially the elderly population. She wishes she can make sure that they are able to perform tasks within their full potential while providing the necessary resources to assist with improvements in functioning. So she considered that her care for the elderly as a passion. So we are glad to have on our panel today for this very important discussion, Madam Joy B. Johnson. Welcome, Madam Johnson. So after all of those introductions,
I'm sorry, Augustine, my mic was muted. I was just saying thank you for the introduction and thanks to everyone on the panel. I'm grateful to be here this morning.
Okay, yeah, great to have you. And after the introduction, we're glad to have all of these great people on our panel today, and it's an honor because with all of the busy schedule in the health setters, professionals like us are very busy. So to be able to have you is an honor, and we want to welcome you and not to delay your time and go straight to what we're here for today. So we're honored to have you, and we're going to be having our discussions today is focused on HIV and AIDS, and the topic under discussion is current available care and management for quality life for people living with HIV and AIDS. So I want to start with the doctor on the panel today with us. He's the specialist, also a medical doctor. Dr. Tekli, we're talking about HIV and AIDS. So what does an HIV diagnosis mean? I'm starting with you as the doctor because the word diagnosis is involved.
Yeah, once more, I would like to say Thank you. I'm honored to be a panelist to discuss this important topic. Yeah, so I'm grateful for this privilege given me. So basically, looking at the word HIV even before even going to the diagnosis. So HIV is what we call the human immunodeficiency virus, and HIV have been around since the 80s, 1980, when it was first 1981 when it was first diagnosed in the States. So based on the diagnosis up to now, HIV has is a public health threat. It has killed almost over 30 million people in the world, and there for any other disease, going back to your question, for any other disease, uh, you have to first diagnose the disease. So as it relates to HIV diagnosis, you have to first be, an individual has to first, go through what we call the testing. So there are various tests that can be offered to this individual, and based on the test result will either be negative or positive. So there are a series of tests that can be done, and right now, if I don't know, I don't want to go into the tests that can be done, but
Yeah,
there are a
we're
series of
coming to
tests that can
that.
be.
We just wanted to
Okay, very
know
good.
what
So there are a
the
series of tests that
HIV
can be
is.
done, and before doing the test, we can either take a saliva or some blood specimen from you to run this test. So, and the test result can either be negative or positive. So that will help you to ascertain to know whether the person has HIV or not. And like I said, it just relates to other diseases. You have to first diagnose it before you know if the person has it or not. Yeah.
So in short, when you do a HIV test and test is positive, that means you have HIV. Is that what I can say in summary for the layman? Because probably we have a lot of non-health professionals listening to us. They may, in a layman term, we want to know what's HIV. So if you do a HIV test and it's positive, you have HIV. Is that what we can say in summary?
So going back to that, we have I would just give the example, of Liberia. For now, in Liberia, a risk individual, for example, because some people will not just walk to the clinic; they want to do HIV test. With the stigma, around HIV because of chronic illness. When you have HIV, if you are diagnosed to have HIV, you're going to live, the rest of your life having this disease. So basically, some people, if you volunteer, for example, you want to do an HIV test, when you go to the hospital, you'll be counseled by this counselor at the hospital. And then after the counseling session, you'll be allowed to take the test. For example, in Liberia, we have 3 different tests based on the WHO standard to determine whether a person really have a true positive or a true negative
Yeah,
test.
so we will come to the different type of the test. That thank you. So I just wanted us to lay that basis first. How do we kind of define what is HIV is? So I think you already said a lot already.
Okay,
So let me
very good.
ask
So yeah, you have to be tested, and when the test result is positive, it means it's positive. Yeah.
Okay, thank you for that. So let me switch over to the public health specialist here. So, Madam Johnson, Pauline Johnson, we have 2 Johnson on the platform, so I have to be specific. Madam Pauline Johnson. So, what is the difference between? What would you say is the difference between HIV and AIDS? Is there any difference?
Sure. Yeah, there is a difference between HIV and AIDS. So for HIV is the virus itself. Like when you are diagnosed with HIV, it means that you have HIV positive virus within you. So the difference between HIV and AIDS is that AIDS is the late stage with of HIV. That is the virus has destroyed the immune system to the extent it went to A stage. So we can say there is a difference. So HIV, we can classify HIV to be the other stage of the diagnosis, and we can say that AIDS is the late stage of the diagnosis. It means to say that you have tolerate to that stage to reach to the A stage. Yeah.
So you can have HIV and you don't have an AIDS yet. You can be diagnosed of HIV, but you haven't gotten to the state where you have AIDS.
Yes, you can. So
yeah, so thank you for that. So Madam Joelle Johnson, are you with us? Being a nurse, a practicing nurse, we want to know, now that we have heard that it's possible you could be HIV positive, but you don't have an AIDS yet. How long does it take for HIV symptoms to start to appear, or probably to say you now have AIDS? Madam Joelle Johnson, are you with us?
I'm here. I don't know what's really going on with my computer this morning, guys.
Right.
Let me try to see. Can you guys see me?
Yeah.
Yeah, so pretty much the symptoms typically start to show up like after 4 weeks of exposure. And it basically start like, just like any regular symptom of like flu, cough, fever, chills. For some people, you will start to have like, genital ulcers, vaginal discharge for women and stuff. So what I would say is immediately you start having these symptoms, it is important that you go to a testing center or you meet up with your medical provider to see if you can get tested. However, I mean, you won't just go to the clinic today and tell them, oh, I'm having headache, I'm having flu symptoms, and they will immediately like test you for HIV or so. But there will be symptoms that you explain to your provider, like maybe you tell them, I've been having vaginal discharge. They might ask you about your number of sexual partners and stuff. So when you explain all of these things to them, then they will recommend you getting an HIV test. But it is also recommended that at least once within a year, when you visit your medical provider for a routine, wellness visit, they should do a HIV test. Or if you present yourself to your doctor today with complaint of having, symptoms of other STIs, it is recommended that they do the HIV test. So pretty much that's what it is for the virus.
This is a very good basis. So I think awareness test is something we should pay attention to. Sometimes we wait until we are chronically ill before we go to the hospital. But I think visiting your doctor or the health facility sometimes just for awareness test is very important. So, the Naomi Flomo, are you here with us?
Yes, I am.
Do you want to come in?
Yes, based on the foundation, the diagnosis, and also knowing the difference between HIV and AIDS, Dr. Twag, Deadly, I'm sorry. I would like to know, do HIV symptoms differ in women and men, or they are the same?
Yeah, so thank you very much. I think just to buttress what the colleague Joel Johnson said, obviously, as you read the put it, when you get the HIV infection, sometimes you don't really get to know if you are infected. It is normal, a lot of symptoms like the normal flu that we have. So most of the time, people will not go, to do a check, but normally anytime around 2 to 6 weeks, those symptoms, will be there, and then later on it will disappear. So basically, in the initial stage, you would not really get, the symptoms as it relates to you, deciding I have HIV, but it would just be like, other, symptoms consistent with flu. So back to your question, HIV at a later age, stage where you have many symptoms being manifested due to some opportunistic infection, the symptoms basically are the same in women and in men. But at the later stage where you have the AIDS now, the AIDS, you have other additional symptoms based on the, anatomical, structure of the woman. You have some vaginal, or what we call bacterial vaginal. We have what we call the PID, pelvic inflammatory diseases, and also yeast infection, in the woman's vagina. And so those are things that would be restricted to the woman based on the latter stage of the disease. But basically, other symptoms are the early onset of the disease. They are basically the same. Yeah.
Okay. Thank you for that question. So I heard you mention something about opportunistic infections. So I would like to know also about that.
Okay, thank you. So basically, when we say opportunistic infections, they are a group of infections that are called when the HIV virus has, damaged the immune system of an individual. Like the first colleague said that this HIV virus, when you get infected, the main target or aim of this disease is to destroy your immune system. It's clever in the sense that it's a retrovirus. So it's clever in the sense that, it's an RNA virus. We have RNA viruses and the DNA viruses. So this virus really attack your immune system. So what it does is that we have other cells, what we call the T helper cells, that if a foreign invader come, or maybe a disease or infection or germs, what's what we call it in the layman terms, attack the body itself has a way of defending itself against this foreign invader. So one of the cells or immune cells that, that can signal to say, oh yeah, this is a foreign invader, and then send their light to another cell is the T helper cell. So what it does is that HIV is very smart. It acts like it is, a part of the immune system. So it evades the immune system. So based on that, a large domain and replicate and start to cause a lot of infections, in and replicate. It starts to cause a lot of infection in the body. So when that happens, the immune system gets, suppressed. You have other what we call, I just told you about the opportunistic infection. So let's say infections that could not cause disease in you. For example, you just getting a normal STI and then getting your medication and, eventually getting rid of that disease. That disease will start to sink in, and then you get severely ill of that disease. For example, those opportunistic infection could range from what we call candidiasis, even TB, because most of us in the sub-Saharan region, we are vaccinated with TB, so, and at that stage, what we call latent TB, so it's like it will recover. So those things will cause, severe illness. And sometimes you may even get pneumonia, the severe form of certain pneumonia. So those are other what we call opportunistic infections because of the suppressed immune system. So those diseases about.
All right. Thank
Yeah.
you so much for that response.
Can I just say something just to add to what my colleague was saying? Like in the layman terms, the Canadian acids will appear like, white patches on your tongue. It's sometimes it will affect your skin, it will affect your nails. So you can even get like tuberculosis, you can get pneumonia because your immune system is weakened and you are like highly susceptible to infection. So like any low disease you get, just like Momo said, like it will just attack you worse than it will attack a normal person. So I just wanted to make that point.
Okay, so based on that response, Dr. Joel Johnson.
Oh, I'm not a doctor.
Oh, I'm sorry.
Not yet, at least.
Okay, Ms. Joel Johnson.
Yes.
So, based on the response from our question, are there activities that are most likely to transmit HIV and AIDS?
Yes, there are lots of activities that can transmit HIV and AIDS. The first one would be like having multiple sexual partners and then having the kind of sex you're having, like anal sex, vaginal sex, oral sex. I know studies have shown that oral sex is less likely to transmit HIV. Or if you have a partner who is infected, and you have like an opening or so on your mouth or something while performing the oral sex, it is possible that you can get the virus. Like if you're sharing needles, sharp equipment with people who have HIV, it is possible that you can get the virus. What was interesting to note was while I was researching, I realized that the possibility of getting HIV through anal sex is higher than vaginal sex. Because then they were trying to say the lining in the rectum, it is so thin. So when the virus attacks, after penetration, when the virus invade the rectums, it because the lining is thin, it directly goes into the bloodstream. So if you're having anal sex, it is highly that you will be infected with HIV. And then I was researching, just putting like the, mode of transmission of HIV in our own setting. Young people are at an increased risk for getting HIV because we're having multiple sexual partners. We, just living, we're not using condoms. We're not taking any precaution when it comes to sex. And it like just the typical Liberian girl. I'm just saying, putting it in a Liberian perspective because most of all on this platform we're from Liberia. Like a typical Liberian girl would definitely have multiple sexual partners. And sometimes it's not because like she want to have those partners. Sometimes like poverty, there can be a lot of different reasons why she's having multiple sexual partners, and she's not, taking precautions when having sex. So I want to say everyone is an increased risk of HIV in Liberia. Because even if you're married and you're home with your spouse, you might think you're only married to that person, but that person is going out having affairs with other people. You don't know who that person is meeting, and you don't know the people connected to the person, like it's just a long cycle. So I'll say like we are all at risk for HIV. So we should take all of the preventable measures to try our best to not, get this virus into our system.
Okay, thank you so much.
So I just want to come in a little bit just to buttress my colleague there. So basically, as you rightly put it, you get HIV. HIV can be transmitted through what we call bodily fluid from infected person, because somebody has to be infected first, and then through the fluid exchange, and the fluid could be either a blood, a breast milk, semen, and vaginal or anal secretion, as you put it. Because those eyes, for example, having anal or vaginal sex with somebody who has the disease could put you at a risk of getting that disease as well. And also an infected mother that has HIV could possibly transmit that disease to the unborn child, all right, or that child that is being born, all right. But there are other means of not getting the HIV, because there are a lot of rumor out there. And because we talk about bodily fluid, some people will say, oh, okay, yeah, HIV can be transmitted through sweat. And in the literature, that has never been, observed that it can be traveled through. I mean, I begin transmitted through shaking hands, through body, sweat, and hugging, and even eating food with an infected person, or drinking water from somebody, like water from the bottle. So it cannot be transmitted through that route. But like Joel's put it, those risky behavior. I want to add one thing, and we are all prone or capable of getting HIV. So when you come across the, medium. So for health workers, we are all health workers here. So health workers are also of getting the disease. So most of you work in a hospital, and you could just get a needle prick, doing of simple venereal procedure, or maybe collecting blood from, or giving injection even. So you will get HIV from those things as well. So pretty much everybody is at risk of getting this deadly virus, whether through blood transfusion or tissue transplantation. You are at risk of getting it through those means. Yeah, thank you.
Okay, Dr. Bala.
Yeah, so with the business late, I want to go to the public health specialist on the platform. The doctor and the nurse have made a lot of clinical business. So I think this question can go across though, but I want to start with Madam Pauline Johnson. So what are some of the care providers on the team you think people living with HIV and AIDS should probably seek help from? So we heard the doctor, we heard the nurse, giving all the clinical analysis there and what happened. I'm a surgeon and I'm also at risk because I go to surgery, right? So if you just mistakenly, break yourself, while you're doing suture, that's trouble for you if you don't know the status of that patient. So that's the clinical aspect in the hospital. But what are other care providers you think the people living with HIV and AIDS should be able to seek help from? I think you give a more broader picture, Madam Pauline Johnson.
Okay, thank you so much for the question. When we started the discussion, Dr. Talik rightly said that when you are diagnosed with HIV and AIDS, the first person that you need to see is a counselor. So some of these healthcare providers that provide aid for people with HIV is they are specialized, like they call them or other health, but other health or practitioners, they are so many dimensions, they are specialized within the mental health, and we find them doing some counseling and therapy. You can also see a primary healthcare provider. A primary healthcare provider with better tissue or better advice advise you with a medication plan, with treatment plans and what have you. So you can also see a doctor, a medical doctor. So a medical doctor, adult health, mental health practitioner, and healthcare provider. These are people like when you are diagnosed with HIV and AIDS for the very first time, and going forward with your treatment plans and what have you. Those are people that you can see for better health, that can be able to advise you on how to go forward with such diagnosis, because we know for some reason that being diagnosed with HIV and AIDS is actually like stressful. It's something that can play with someone's mental health and what have you. So it's best that you see primary healthcare provider, mental health specialist, and also a doctor, or those that can be able to advise you directly on what to do or go forward. Thank you.
Okay, before I go forward to the clinicians, you focus on research area, mental health, and people need to focus on people with HIV and AIDS, talking about quality of life. So what are some of the services you think when we seek those public health specialists, like you talk about the other health care providers, probably or nutritionists, these are public health people, right? The nutritionists, the mental health specialists, and these other health practitioners. What are some of the services that people living with HIV and AIDS are expected to benefit from, and how can it improve the quality of their life?
Okay, so basically research, people research make tremendous an effort with regards to treatment for HIV and AIDS. That's to control and prevent HIV. But now the research are focusing direction on how can we manage the quality of life of these people living with HIV and AIDS. And basically, when you look at the quality of life of people living with HIV and AIDS as it relates to the diagnosis, we found that there are more emotional stress that is associated with HIV and AIDS diagnosis, especially for those that have been diagnosed newly with HIV and AIDS. So what a mental health or what a primary health provider can do for those living with HIV and AIDS is basically to advise you or to help improve some of these stress that is associated with these diseases, and they will better advise you on how to take your treatment, because with this treatment, the sooner you take the HIV treatment, better for you, the better that you can improve. So there have been also research that have also associate that people living with HIV and AIDS, that the better nutritional plans is better for their health. That the research have found that the more healthy they eat, the better the quality of life. So nutrition in this sense can advise them on what dietary plans that they can engage into, what dietary plans that they can eat, or what foods that they need to eat to better or improve their quality of life. So when we talk about mental health professional, what the mental health professional can do, because we know that being diagnosed with HIV and AIDS is mostly associated with stress and emotional distress. So people within the mental health field can better counsel you on and how to improve your quality of life, or how to for better coping strategy on how to cope with this disease and what I feel, yeah, and how to cope with stress, cope with emotional stress, psychological stress, and like that can be like a better way to improve your quality of life. Yeah. Thank you, sir.
Dr. Bala, are you there? Dr.
Like
Bala?
yes, like we lost Pauline Johnson. Can you hear me?
Yes, I can hear you, sir.
Oh, okay. Yeah, so thank you, Madam Johnson, Pauline, for that brilliant explanation. Now I want to go over to the clinicians, right? So what are some of the techniques? You were initially talking about the test, and I said we're coming to that. So what are some of the available testing method that is currently in use to help monitor HIV? What are the different testing we have?
Thank you for your question. So basically, there are a series of tests that we can, that are available right now, and we categorize them into three types of HIV diagnostic, test. The first one is what we call the nucleic acid test, it's NAT for short, and another one is the antigen antibody test, and also the antibody test. All right. So the NAT looks for the actual viral in the blood. All right. And then it also identify the viral load. So basically, for instance, when we say viral load, the amount of virus, the HIV virus that is in your blood. So that NAT test can also, identify how many virus you're carrying in your blood. And also the antigen antibody test can also look for the particular, it can look for both HIV antibodies and antigen in a serum or the saliva. Because like I said initially, we can use your blood or the serum to run the test. So the antibody test now will look for the antibodies to the HIV in your blood or the oral fluid. So I'm just saying that these are medical terminology, but I'm going to go back. So basically, having an HIV test, for instance, we might take your the saliva or the blood, but most often we take the blood from your finger prick. All right. So we have series of self-tests that is used right now, rapid tests that is used. Some of these tests can be bought in the pharmacy, in the local supermarket, and some of it are deposited at the specific site or in hospitals or healthcare centers around. So for Liberia, for instance, we have what we have 3 different tests, self-tests or rapid tests that we can use. So the first one, we have what we call the Determine, we have the Bowline, we have the Unigo. So for instance, somebody coming to the hospital, most of the time, I was just giving an example on pregnant women. It's mandatory that pregnant women attending antenatal care do HIV test as part of a routine visit. As part of a routine test. So for instance, she will get counsel, and then she gets
Dr. Tekli, let me interrupt there.
Yeah.
Let me come in there to see whether I can help some of the non-medical people that will listen to us later to get a picture. When you say rapid test, so is it like a pregnancy test, HIV test is almost like something maybe you can go to the pharmacy and buy in and secretly go in the bathroom and check your status? Is that possible? Is that what you mean when you say
So like
test?
I said, it's a self-test or a rapid test that you can just go to the pharmacy and buy and be able to do it. For example, most women sometimes when they miss their period, for instance, they go and get the pregnancy test. It's just the same thing like that. So you can go and buy it and just prick your hand. The direction is there. So long you follow the direction and you get a finger prick, the drop of blood, you put it on that test strip, and then in the course of 20 minutes, less than 30 minutes, you can be able to get a result, whether negative or positive. So, but in the clinical setting, some people think that, when you do that, there are other tests to follow to determine whether you are actually true positive. Because we're not going to just do one test for you, or you just do one test, okay, I have HIV now. No. To give credibility to the test, and also because it's a chronic disease, and like Pauline was saying, there are a lot of stigma attributed to this disease, and it's a chronic disease that when you get it, you have to live with it for the rest of your life. So it's important. For instance, like that's why I was trying to give the example in the Liberian setting. So for instance, when we do the first test, for example, in a hospital, we have to do two other tests using different rapid tests to really ascertain whether you have the HIV virus in you. And because when we determine that you have the HIV virus in you, then we immediately start treatment. Okay.
So what about before I go on? So to the audience, we're gonna have time for question and answer. I already see somebody sending question in the chat room. So definitely, we're gonna have that section where you can ask your question. You will unmute yourself and call your name and ask questions. So just start jotting down your questions. I see that Janento Maningogo had hand is up. We'll recognize you later. Please start. So at the end, we're going to have question and answer time and comments as well, so that we can be able to get a lot from this discussion. So, but please bear with us. Let's get to the end of the discussion with the panelists. So, what about the issue of CD4 count, viral load test? You know, you just talked about the rapid test. When do people think that CD4 count, viral load test becomes important? Is that something you want to explain that people who are living with HIV and AIDS want to know? Well, I just did a rapid test. Okay, now probably the person know they live with HIV and AIDS. What are the other tests? What is the significance of those tests to them, like the CD4 count, the viral load test?
Okay, thank you. So, like I said, when we look at CD4 count, the normal CD4 count is between 500 to 1,500 cells per cubic milliliter of blood. So the CD4 counts, decreases over time in the person who are not receiving ART, what we call the antiretroviral treatment or therapy. So before, let's say you are positive of HIV, the doctor say, oh, you are positive, and it's cleared, has been established that you are positive with HIV. So before 2016, we would, in clinic, before we even administer the treatment to the patient, we'll wait until your CD4 count falls below 500 before we start putting you on therapy. But as of 2016, all right, it was changed that so long you test, you have to treat. Whether the person's CD4 count is in normal range, you have to treat. So we initiate therapy. So CD4 count is very important because CD4 count will determine how the immune system is functioning with this disease in the body. All right. So if the CD4 count is very high, we know that, and you are on therapy, we know that, okay, yeah, at least the drug is working, and then because our goal is to have a viral load that is undetectable, because we know that undetectable viral load will mean that you will have a no transmission of the disease. All right, so we are trying our best to at least let the viral load reduce. So the viral load, as I just mentioned, is also very important. Like I said initially, that when you're infected with this disease, the HIV replicate using the cells in the body, our own cells, and replicate itself. So after this replication, and you are on, for example, like I said, you are on, you are diagnosed now. We also use this viral load to determine whether you are doing well on treatment or not. Because as the viral load increases, we know that definitely you will get sick, you get sicker. So, but if the viral load is undetectable, then it means that the treatment protocol is working. Okay, so it's very important to determine the CD4 count in a patient who is positive and a viral load as well, because it shows us as clinician to say, okay, yeah, the drug is working or not working. All right.
So your CD4 count, your viral load, going to give a kind of monitoring a picture as to how well you are doing if you are on medication, or how bad you are probably doing. right?
Very
So,
good.
Madam Joel Johnson, we heard Dr. Techley talking about the different tests, and he even talk about, I think he mentioned false negative, false positive. So, you as a nurse, I think the nurses, you guys, you had the opportunity to see, a lot of the results and interact with the patients a lot. The nurses, you guys have more access to the patient. How common is false negative and false positive? Like,
I mean, it's not really common, but there is always a chance for you to get a negative result. Just by listening to what Dr. Tegley explained, like if you go to the drugstore and you buy the rapid test, you go ahead, you do it yourself. It is possible that you might not be doing it correctly, and that might, result in a false positive result. So, I mean, even with the lab test, like if you're even doing it in a hospital or a clinic, if you're doing it in the lab, there is still a possibility for you to get a false positive result or a false negative result. So I think it is important, like what he stressed on, to just perform series of tests just to be sure, and don't just rely on the first test, because there is a possibility that, I mean, nothing is so extra perfect. There is a possibility that you could get a false positive result. And then just listening to him, it made me realize that mental health counseling is very important in the diagnosis of HIV. Imagine you going to do the test yourself and you find out it is positive, but it's just a false it is just a false positive result, like that's why you need to be counseled, like even after you get your result. So what I would say is, based on what I've heard or what I've learned, I think it is important that you go to the clinic or you go to the hospital to get yourself tested. Because if you're buying the test at home and you're doing it yourself, you don't have anyone, counseling you of what to expect when you get the result, what is the complications. Like you just need to be really counseled on, have information on everything before you go ahead and do the test. I know it is okay to do it at home, but I would still recommend that you go to a clinic where you will have all of the support that you need from the medical providers, from everyone, to get yourself tested and not just rely on the rapid acting test, because there is a possibility that you could actually get a false positive result. And before I conclude, Pauline Johnson, Miss Pauline Johnson was, making emphasis on things to improve the quality of life for people affected by HIV. And one thing I wanted to mention was, it is very important to consider the social economic status of a patient that is diagnosed with HIV. Like, especially in our setting, if you have the disease, most times people don't take their medication. And if you don't take your medication, it makes you susceptible to infection, you get sick easily. And if you're sick, you're not going to be able to work. If you're not working, you won't be able to care for your family. You won't be able to care for the people who depends on you. You won't even be able to care for yourself in the first place. So I think social service is important to provide, the necessary assistance that is available to the patients so that they can utilize these assistance and not just stay home and not do anything. Like, they will provide you the adequate resource that you need to go through your sickness. So I just wanted to make that point too.
Okay, thank you.
Thank you. So,
Thank you.
as a clinicians, I know when we have patients that knows HIV/AIDS, of course, now, if you are in OBGYN, every pregnant woman going for antenatal care, they have to do the HIV test. So definitely you have some positive patients you have to care for. And if you are a surgeon, any patient going for surgery, of course we do HIV tests, you want to know. And there are some patients you're going for, you have to do surgery for their HIV positive. And we are all even sometimes very scared, like, oh, this patient, sometimes before you go for surgery, you check in the chart, you check for HIV status, so you know how many gloves to wear, how careful to be, all those kind of things. But I think the picture has been that HIV initially sounded like a death sentence, like how we are all afraid of COVID, like, oh, you get that diagnosis, you are dead, right? So my question now is, currently, we've been hearing about HIV for years now, right? It's been around for a while. We have a lot of people living with HIV/AIDS in the church, along with us in the hospital, in our schools, and just everywhere. So some of them probably don't have some of this basic information. My question is, starting with Dr. Tegley, what are some of the available treatment, medical treatment for HIV/AIDS right now? Including vaccine. Is there any vaccine? Is that Tegley still with us?
Yeah. Thank you so much. Do you get me?
Yeah.
Okay, very good. So yeah, to be honest, and there are a lot of improvement since the 1980s as it relates to the antiretroviral drug. All right, there have been new
So that's
drugs.
the name of the treatment. I want you to kind of make it also a little simple because
Okay,
we
very
have some
good.
young medical practitioners listening.
Okay, very good. Thank you. You keep on reminding me, but it's good that we communicate, because since we're talking to the layman, we have that simple way of communicating that they will understand. So the HIV medication that we're talking about is called, in total, the umbrella word for it is called antiretroviral drug. So sometimes we call it ARV. All right. So these drugs are a group of drugs that if a person is positive, we can be able to give it to them, and then they will have to take it the rest of their life. So there have been a lot of drugs being developed since this disease was established in the world. So the first drug was, developed around 1985, 87. It used to be called AZT. Sorry, I will not call, because it's a big name. I will not call the name. So, but anyway, over the years, there have been new drugs coming up, and we have what we call the ARVs. We have a different type of it. Just this, a few years back, we have a drug called the TLD. Is a combination of 3 different drugs that now you only have to take a single tablet, because before, a lot of the time, people will be diagnosed with HIV and placed on multiple drugs, and these multiple drugs sometimes is very cumbersome or very difficult to take. Every day taking more than 3 drugs a day. So now there have been tremendous, improvement. So we call it the TLD, single tablet a day that people are taking for now. So that has been a great improvement in the development of the antiretroviral drugs. Another thing we have is what we call the PrEP. Pre-exposure prophylaxis is also a medication that, for example, as the word depicts, pre-exposure prophylaxis. For example, if I'm a doctor or you surgeon working in a hospital, and let's say you got a prick of a patient, maybe you're in an emergency setting, it's not an elective case to see, you're going to do all the blood work to know the status of this patient. Let's say, somebody was just in the ER and the blood patient, already I went there, and even I had a glove on, but then I had a needle prick, and I don't know the status of that patient. So basically, right there, I have to tell maybe the HIV specialist in that facility that, oh, I got prick and I need a PrEP. So the PrEP now, it can be taken from 24 to 72 hours. So when you're exposed to certain dangerous, situation, like you got a needle prick, or you came in, you had sex with somebody who you didn't even know their status, and or a victim of a rape, most of the time you will not decide to be, raped. But if you are raped, or the child is raped and it was brought to the hospital, in that time, we can also give what we call the PrEP medication to them, and it works very well. All right, the success rate is very high. So when you take it, it will help to kill the HIV. If that person, for example, who got raped, maybe the person who raped them had HIV, definitely that patient or the person being raped will not be able to get the disease if they take the PrEP. And you, as a surgeon too, who got outbreak. If you take that, the PrEP medication, it will also increase your chances of not having that disease if that person had that disease. All right, that's number one. That's number two. Another one is called what we call the post-exposure prophylaxis. All right, post-exposure prophylaxis. Oh no, sorry, I was going around. So the PEP is one, for example, I was just talking about, but the PrEP, for example, now, if I think I'm a sex worker, sorry to say, so it's a post-exposure prophylaxis, what we call the PEP. So that one, maybe, like I was just giving an example on, but the PrEP, P-R-E-P, the pre-exposure prophylaxis, those one, for instance, if I'm a sex worker, all right, or I'm a RICS, maybe I don't know a status of anybody, and you can be able to get that medication, it will be able to prevent you. So the PrEP can be taken like daily. So if I take that medication, maybe even somebody who have HIV, I cannot be able to get that HIV. All right, the success rate is almost 99%. Especially vaginally. All right. So long as I have sex with that person, you will not be able to get that medication. But in outside of this world, so for example, Liberia, we don't have the PrEP yet, REP. So it just got approved around 2010 by FDA in America. So they are still trying in Liberia. We're still trying to formulate a guideline to be able to use that, from a reliable source. It will be used in sex workers or people in prison or in the mine area, because those are people who are exposed to, multiple, sexual partners, and they pay for sex. So those people, they will try to pilot it. It means that they'll try to give it to them if it's available in Liberia. All right, I'm just trying to give an example, but other countries already have been having this PrEP medication, and they are using it, like in the US, South Africa, other developed countries as well. They have been using it. So we have what we call the ARV. Under the ARV, we have these differences. The different ones, like the PrEP and the PEP. The PEP is what we call the post-exposure prophylaxis. It's good. That has been in Liberia, and maybe if you get exposed to any risky behavior in the hospital, you can be able to take those things. It can be able to help you at least to minimize your chances of getting the HIV. Thank you.
Okay, so the pre-exposure, that means before you get exposed, right? And then the post-exposure after you get exposed. All right.
Very good.
Thank you so much for that. You didn't mention, you didn't talk about that. You think Johnson in research area, you want to tell us, is there any vaccine, or you have any idea in the research world in infectious disease, whether there is a vaccine in process? Is there any research talking about people working on vaccine for HIV?
Currently, there's no vaccine for HIV and AIDS. So yes, like Dr. Eddie said, it's just currently, it's just now the drugs that they are using to prevent and control HIV and AIDS. So there's no vaccine currently.
Okay.
Yeah,
So we want to continue the discussion.
I would like to. I would like to throw a little light on the vaccine development in HIV. In HIV and AIDS. So, like we said, this disease is a tricky, virus. So the scientific community have really tried since the disease was first detected to really develop a vaccine, but there have been a lot of failures, a couple of times, that they haven't been successful. But again, recently, I do a consultation with what we call the International AIDS Vaccine Initiative. It's called IVA. We currently trying to work on this hepatitis B vaccine rollout in Liberia. So that group is readily working with Modena. I think Modena is a vaccine development institution that even helped to produce the COVID-19 vaccine. All right. So this group is working with other groups, and Modena used a specific or certain type of vaccine development strategy, what we call using the mRNA. All right. So they've been initiating this study, but then they have some failure along the way. But now, with the collaboration with Modena using this new vaccine strategy, they got some success story early on this year, and they are still trying to pilot it or to, move from one stage to another stage, because we have 3 different or 4 different stages in vaccine development. So they got some success story, and they are trying to, because I don't want to go into the detail of the whole vaccine development, but there's there's a prospect along the way that we might in the near future, Eric, we might be able to get a vaccine. Like I said, COVID did a lot of bad things, but one key area with this new technology that they use, they are trying to harness on, tap on that technology to be able to develop a new HIV vaccine. So it's on the way as we speak to you.
All right, so my co-host going to continue this conversation. Manadine, now, Flomo, are you with us?
Yes. To Madam Pauline, based on the treatment or medication, based on the treatment of the HIV virus, does the HIV medication cause side effects?
Yes, there's some side effect with regards to the medication of the HIV virus, because some individual have a different system and they deal with this medication differently. So there are some side effects, but these side effects are something that can be controlled for. Like when you are in communication with your healthcare provider and your doctor, so they can be controlled for. It's not something that is so serious. So this side effect of the medication can be controlled for. So yes, there is a side effect as it relates to the antiretroviral drugs.
But that can be controlled, right?
Yes, they can be controlled.
Okay, thank you so much. Ms. Joel Johnson, I would like to know how to improve the quality of life for people suffering from HIV who can afford their hospital care.
That's a very interesting, point to make. Like, for people who cannot afford their hospital care, I think there should be program and policies in place, to help these people. Because if you have HIV and you're like really sick, you definitely won't be able to work. And that's what I was talking with, where the social services comes in. Like, there should be easy access to testing. There should be different programs available to, help cover up these people medical bills. And currently, I'm not over here in the United States. We do have insurance, like, and they have different Medicare and Medicaid programs that cover the insurance, covers part of the insurance bills of people with HIV. I'm not sure what it's like in Liberia. That can you give any information on that?
Yeah, thank you so much. Just to go back a little bit, quality of care is very important, and there are various ways that we can at least achieve quality of care of people living with HIV and AIDS. So number one thing is treatment coverage, universal access to this ARV we're talking about, or the medication for ARV. Before, during the 1990s and earlier on, it used to be very difficult for people in lower middle income countries to really get access to the drug. So they really die from the disease. But with, the UN body that coordinates the AIDS, it's called UN-AIDS. And through the Global Fund, there were a lot of money or investment made into the research of new drugs and vaccine even. So, like I said, they have new medication now that they have. So, and the Global Fund at it was in 2011, we had this goal, this ambitious goal that, for example, it's called 90%, 90%, 90% goal that was set for 2020. So the 90% goal was needed the first 90 was set to know, at least to reach 90% of people to know their HIV status around the world globally. The second 90% was, if you know your status, you should be able to receive medication. So the second 90% was, at least we should reach 90% of people who have been diagnosed to at least have access to the ARV medication. And the third one was what we call the viral suppression. Like I told you, that if it's viral load is undetectable, it means that it will lead to untransmissibility. It means that the person will not be able to transmit the disease. But this goal was just a part of a big goal. So in 2014, they came back, they reverted to another ambitious goal, what we call the 95%, triple 95%. All right, they still want to achieve that. Okay, yeah, people should know their status. 95% of the global community should know their status. 95% should get access to the medication, and then the suppression of the virus. So, but there are a lot of things interplaying. Most countries went to some declaration. For example, Liberia, as a country, went to the Abuja Declaration. All right, I want to make the example, like Joel was saying that I should – if I have any example to give on Liberia. So they went to these conferences and made an ambitious declaration of commitment to say, okay, we'll be able to Liberia now and say, okay, we'll be able to give at least 30% of our national budget attributed to health. And they went again and said 30% of that budget that will be attributed to health with 30% and attributed to fighting HIV, TB, and then tuberculosis and HIV, right? But we don't see the reality because it takes a political will. In the West, it's different, but here in sub-Saharan Africa, it takes a political will because if you make such a commitment, you should be able to also provide your own, side of the bargain because the Global Fund, have grant that it can give out, but as a country as well, you have to also support that grant. All right, but we as a country, we're not doing that. Even now, we're talking about viral load. Although we are giving medication to people who have HIV in Liberia, but we are not detecting. And there are a lot of reasons why we're not detecting the viral load. And it's very important to detect the viral load because you have to have a well-structured lab to be able to detect, to be able to do like a gene expert. We have this PCR testing. We know, it's a big word, but at least a common man now with the advent of the emergence of COVID-19, we all know what you call PCR. So we use the PCR also to detect viral load. So if, for example, if you don't have those equipment, the gene expert cartridges or even a machine to run these tests, you run a risk of having people on drug, but you don't even know their viral status, viral load status. So government as well has to take on some initiatives, commitment made. They have to at least, be able to hold their side of the bargain to ensure that there are people who own HIV drugs, get the drugs in time, they get the regular checkup, and that will at least facilitate, their living with the HIV, at least to near less pain. All right, and that's not another one. Another thing is to get rid of what we call stigma. Stigmatization is very, very cardinal in helping people get rid of this disease because our country is enclosed. So that the technically has HIV, when somebody knows about it, the whole community will know that I have HIV, and that alone, I will be rejected by my community, and that alone will have a mental state. It will affect my mental state, and that might lead me to my other demise. So there are a lot of ways we can also help support groups, even families, people who, we have a certain, a group of people here who are infected because we have different people from different backgrounds who have HIV in Liberia. For example, now, Liberia, we have the highest proportion of people of prevalence of HIV infection is among people, men who have sex with men, or female who have, who are sex workers, all right, and transgenders, and people who use drugs and inject themselves. So these are, category of people that are highly infected with HIV. So amongst them, they also have support group. So if you are newly diagnosed, your friend is already on ARVs, they can also help you to say, okay, yeah, this is, is what it is, this is the reality, but when you take your medication on time, you'll be able to live long near your lifespan, So that's just, that's just my 2 cents that I wanted to put forth there. Thank you.
Okay. So just to add what Dr. Teddy has said and Joel, yes, with regards to quality of life for people living with HIV and AIDS, yeah, I and my professor, our team, we did a study on quality of life and the health-related quality of life of people living with HIV and AIDS, and we found out that those living with HIV and AIDS that have more support, like he said earlier, from their families or friends, their quality of life was actually good than those that were having lesser support from family and friends. And another thing again is adherence to judge. So we found that those that have primary care provider or maybe a mental health counselor that could advise them on how to take their jobs or how to adhere to their jobs, their quality of life were actually good as compared to those that have no adherence to the jobs. So like, with regards to the jobs of HIV and AIDS, it's very important as it relates to new diagnosis, especially for those that have been newly diagnosed with HIV and AIDS. Their quality of life is actually important. So I think for intervention and policies, we should pay more attention to these things, like with regards to discrimination, stigma, and other things that can deteriorate those that are living with HIV and AIDS, to like the psychological distress and what have you. So it's actually important for us to give credence to these things, like intervention policies, to be put into place for those with this disease. Yeah, thank you.
Thank you so much.
Just to say something, I don't know how true it is that I was just reading a recent research that was done in this 2021 on HIV and AIDS in Liberia. And they mentioned that the National AIDS Control Program, they have really done like significantly well in managing HIV and AIDS in Liberia, because the HIV prevalence declined from 12.4% in 2004 to 1.3% in 2008. Like, that's a huge gap. So I think they're trying their best. We should just continue doing what we're doing right now, and maybe just explaining. I mean, they're already doing it, but just to continue explaining like the good effects of the drugs, like why it is important to take the drugs, and as it relates to the whole stigma thing associated with the HIV. I think it should start from our homes. Like, when we are not having sexual conversations, like our parents did not have sexual conversations conversations with us about, anything. That's what I'm grateful for this generation, because, we are trying to change some of the dynamics of HIV. I don't know about other people, but like where I grew up, my grandmother wasn't telling me, oh, when you do this and you do that, you can get HIV and AIDS. The only thing I heard about AIDS was if I didn't wait the age I was supposed to reach to have sex, if I had sex before that age, I wouldn't get HIV, and if I get AIDS, I would die. Like, so imagine, imagine growing up your whole life knowing that, okay, this disease, when you get this particular medical condition, you will die. Like, it's the only thing that comes to your mind. So definitely, if all of the kids in the neighborhood who have the same mindset, nobody will want to associate with anybody who have the disease. So I think it is important, like, it should start from our homes, like have this conversation with your kids, especially for teenage girls. Like, at the end of the day, you definitely know this person will have sex at a particular time. And don't just say, oh, when you start having sex and then you having multiple boyfriends, you're going to get AIDS, and when you get the AIDS, you will die and stuff. Like, tell them about different STIs that they could get. Like, tell them about the risks, tell them, like, just explain, go in detail, and not just make it look like as soon as you get this disease, you're going to die. So that's just another point that I wanted to make.
Hey.
Thank you.
Okay, thank you so much for the response. So it's really important to support those who are living with HIV and AIDS, to support them, for their mental well-being. So that's key. And over to Dr. Bala.
So I already getting a lot of questions from the chat room around, and some of the questions from the chat room already pointing to some of the questions I'm going to ask. So I may probably just run to the chat room and pull these questions. And some of the questions I had to ask, you already answered them. So what I'm gonna do now, we actually gone into the question and answer time. So I'm going to take these questions from the chat room, and then before we can ask people to raise their hands. So somebody asked in the chat room, is it advisable to marry a person living with HIV? If so, will our unborn kids be affected by the virus too? So that was the question I asked, in terms of how can people live with HIV is safely conceive and protect their babies, like whether during the pregnancy, during delivery, and after delivery. So somebody just asked that question. So can we go to that? Is it advisable to marry somebody with HIV and AIDS? If yes, how can they be able to conceive and protect their babies from getting the virus? Maybe we can start with the doctor in the house. Dr. Ted.
Yeah, so basically, I wouldn't say, yeah, so we always try to get rid of discrimination. So that's why we are very particular of the language we use, right? So for instance, maybe, yeah, I love a girl and she has HIV and I really love her despite her her status, because it's crime in nature to concede your status. All right. If you have HIV, you have a partner, by law, you need to, disclose your status to that partner. Again, it's a tricky bit because sometimes you might think, okay, if I just disclose this and this person will just leave me and go, and my name will go around, and that stigma or discrimination thing will come on me. But anyway, so let's go back to the question. So if, for instance, my partner has HIV and we are married, let's say, or I decide to marry her, all right? So there are other ways that we could I could prevent myself from contracting that HIV from her. So number one thing is to ensure that she's regularly on her ARVs. All right, she needs to take her ARV regularly because, like I said initially, if you take the ARV or your medication, the viral load will be what we call undetectable. It means that when it's undetectable, it will means that you will have a small chance of you passing the viral to another person. All right, the chance is just 1%. So long your viral is undetectable, the chance that you have sex with somebody and then transmit that disease is very low. All right, so in that process, I can have sex with that person, using condom. That person will not get infected. Or let's say if I decide to say we want to have a kid with, all right. So when I go about, so when the person viral is undetectable, I can have sex with that person, and then if the person conceive, definitely that child, what we call prevention of mother to child transmission, the PMTCT. That's why when you go to the hospital as a pregnant woman, they can be able to do your test. And if you are HIV positive, is that you tell the clinician or your care provider that I'm positive, and then they will encourage you to keep taking your drug. All right, and then let's say you decide to born that child. Before, we used to do what we call C-section. All right, sometimes it might be advisable that you do the C-section, so to minimize the risks of that child getting the disease when the child is born. All right, so the C-section, but so when your viral load is undetectable, the chances that even when the child is born vaginally to contract that disease is very low, like I said, 1%. So long your viral load is undetectable, you can even born that child vaginally, that child will not be having that disease. So when you born the child again, for instance, whether through C-section or through vaginally or natural birth, when that child is born, that child, as soon as that child is born, the test is done. They do the HIV test for that child to know whether that child has a disease or not. So let's say the child does not have the disease. So again, like we said, HIV can be transmitted through bodily fluids, we name it like vaginal discharge, through breast milk, right? I said that. So let's say that child is born and The mother is an HIV positive mother. So now the healthcare provider can encourage you to, if you have the means, your social status is good, and you have the means of having what we call the formula field, we advise you not to breastfeed that child, and you put that child on formula field, and that child will continue to take that formula field. So when the child is negative. All right. So let's say again, in the case wherein the mother does not have access to formula field, so we say that you should exclusively breastfeed that child, even if you have the HIV positive. You are HIV positive. You will exclusively breastfeed that child for up to 6 months. All right. So again, when the child reaches 6 months, maybe you try to wean the child off the breast milk, we'll be able to do the test again to determine whether that child have HIV or not. So there are other possibilities that you can born a child, and then that child will not have HIV. All right. So long you on your drug regularly, and that viral load is very undetectable, that child might come out of not having that disease, and the child will live a free HIV-free child. Okay. So that's it. If there's any follow-up questions, you want to have follow-up questions, you're welcome to ask now. I will
I just
provide.
have a question.
Yeah.
You just
Yeah.
oh, sorry.
I'm sorry. Want to say something? Yeah.
I just
Yeah, sure. Please go ahead.
You mentioned the different, ways that the child can be affected, and everything you said is very true. Just so you know, like if you so in love with this particular person and this person is the only person in the world that you want to spend the rest of your life with, you should know that there is a high risk for, infecting your child with the virus through that person. My question is, it is usually advisable for the HIV mother to not breastfeed the child. So you just mentioned that if you have, if you can afford the formula feed, it is okay for you to not breastfeed the child. However, if you cannot afford the feed, you have to exclusively breastfeed the child for 6 months. So, I mean, I don't know, but I believe even if you're exclusively breastfeeding that child for 6 months, the fact that you giving the child your breast milk and the virus can be transmitted from your breast milk to the child. Are there any available resources that can be provided to mothers who are not able to provide the feed for their children?
Oh, thank you so much. Yeah, so it depends. This is individual, based. So it differs from individual to another individual. So I just give the context so you know that, because in the research, and that's what is done practically. Some people will not be able to afford, but let's say, for instance, and as a care provider, if you born this child in the hospital, we'll be able to provide the various options, like I just said. So it's ideally, like you said, it's can be advisable that you should not, because like I said, if your viral load is undetectable, there's still a 1% chance that child might have.
Yeah.
Yes. It's also prudent that, like you mentioned, that the person be fed on formula. But let's say the person does not have, what you do? All right, you just have to give the breast milk. But
So are there any?
there are other means. Social. That's why social worker. I mean, work.
Yeah, that's what I was going to ask. Are there any programs or policies in Liberia that provide, nutrition for breastfeeding mothers with HIV, or formulas for kids born to HIV parents? Like,
so that over my head, I would not. I don't have that information.
okay.
Like we know, for example, the malnourished kids, their formula fees are free, for that. But over my head, I will not give you that answer. But I think if they have that, then it should be the right way to go to provide also parents to really do their best at least to provide that formula fee. Because in Liberia, normally, even if the person does not have HIV, how many people in the rural area?
I know, and that's what I was just thinking about.
Yeah.
Like, how many person can afford?
Yeah.
This solid food, introduce solid food at a tender age, So basically, is that, but you can advise them not to, be able to give, the breast milk. That will also be like 100% chance that the patient will not get. I mean, not the patient, but the child will not get.
Okay. All right. Thank you, Dr. Momo.
Yeah, so I think that where social services should come in, right? So people from even the religious sector, the church, different organizations, I think there where you can come in also to help, right? So we're talking about the different care providers. So I mean, not just medical, but social services and care are also very, very helpful in that context. So let me take the last question from the chat room, then I will recognize the hands that are up. So the question say, is it more important for HIV infected individuals to undergo screening for diabetes, osteoporosis, colon cancer, and as appropriate? And should they also be vaccinated against pneumococcus infection, influenza, parasitia, and hepatitis A and B before they can start treatment? If yes, why? If no, why? Should they run all these tests and if possible have vaccine before they can start treatment? A follow-up question to that, including COVID, if the person is HIV positive and then they get COVID, how are you going to balance that? What's your advice?
Okay, that's a brilliant question and an interesting one as well. To be honest with you, when you have HIV, if you're diagnosed, like we said earlier on, sometimes people get HIV, they're living with HIV, but they don't even know their status because it comes on like simple flu and then it disappears and the person have this virus in them and they're living on. And before it turns to ARDS, the latter stage, it varies up to 6 to 10 years. It varies per person or individuals, right? And let's say if you are diagnosed today that you have HIV, treatment should not be withheld. You should start treatment and encouraged to also take those vaccinations, for example, against hepatitis B, the flu shot. You can get a yearly flu shot as an HIV patient, because we don't want you to have what we call the opportunistic infection, because those things, you eat very good, very good. So if you're not even regular on your medication, and then you have other opportunistic infection, like you have what we call typhoid fever, for instance, with a low viral load or CD4 count, definitely you will be prone to getting what we call being severely sick, and then it might lead to AIDS. So it's good, it's encouraged that so long you are diagnosed, your healthcare provider should at least give you a range of other vaccination that you need to take, and it can help you to avoid being prone to getting opportunistic infection. So it's very important that you can do it. Yeah. So as it relates to the the COVID-19. So COVID-19, to be honest with you, people, and I will say this, for the listening audience there. So COVID-19 happened very sudden. It's an unprecedented situation that we've never seen. We've seen it before, but this one was so, to the extreme. So the vaccine development took a shorter course than expected. All right. So because of the people that were dying, all right. So they had to develop vaccine very fast. So now, during that vaccine development, they did not take most of the vaccine development agency or institution. Some of them, like the Moderna, took a few of HIV suspect or subjects or participants. And because you have to try it, you have three stages also. The fourth one is just marketing, but you have three major stages in vaccine development. So basically during that time, you have to bring on board at least every member of the population has to be there. Sick people, people who have chronic diseases have to be represented in the clinical trials. All right? You have to introduce this vaccine then, and it's really see the response in them, if it is working in them or not working in them. So there were a few companies, vaccine developer, really introduced those immunosuppressed or HIV patients. And they found that it really worked in them as the number of people who never had HIV. So they decided that, okay, CDC decided that, okay, let's give the vaccine to everybody, irrespective of your HIV status. So if HIV people or infected persons are taking the COVID-19 vaccine, and we are even encouraging them to take booster doses because we help them a lot. All right. So, and there are other things too, as if you are infected, there are other things you need to, other risky behavior you really need to be cognizant of, because you don't want to be infected and be doing those risky behavior, and then that might lead to even getting the AIDS and having opportunistic infection. So it's also encouraged that you should take COVID-19 vaccine irrespective of your HIV status. Thank you.
Thank you so much. Thank you so much. So I'm going to start taking questions from the audience, and I'm Dr. Augustine K. Bala. I'm being your host today, hosting you from the commercial city here in Southern China, Guangzhou. And my co-host is Dean Naomi Flomo, joining me from Black River, St. Elizabeth in Jamaica. And we've been having on our panel today, infectious disease specialist, a medical doctor, infectious disease specialist, Dr. Momo Tegli, joining us from Liberia. And also Madam Joel B. Johnson, joining us from Minnesota, the USA, and of course, public health specialist, Madam Pauline S. Johnson, also joining us from Changsha, China. So we're gonna be recognizing a few people who have their hands up. I think I see two hands. Initially, I saw one hands up, and now I see another one. The other person have put Dr. Jonathan Maningogo Hart. You had your hand up earlier. Do you still want to ask your question? So if Dr. Maningogo Hart is available, you can unmute and ask your question. After Dr. Hart, I will recognize James Sonkale Wiami. Dr. James Sonkale Wiami will follow to ask his question. So Dr. Hart, are you available?
Hello. Are you getting me?
Yes, Da. Yes.
Nice to see you guys. See the way you get for me back there. Okay, thank you for the discussion. And I think that these discussions are necessary to help, stimulate the public and keep the public aware of their responsibility, because health itself is not just the health practitioners, but the public itself has a responsibility to play in the health process. To achieve a better health outcome, you need a total involvement and understanding of the population and even the sick people. So thank you very much for this topic that most people don't want to discuss. And I just wanted to ask two questions. The first question has to do among this series of tests that Doug said are available for screening of a patient suspected or wanting to do HIV tests. Which one is the most accurate or the most reliable one in modern days? We have the first generation, second generation, third generation, and fourth generation. I learned that the first and second are not be in use. So between the third and fourth, which one will you recommend, or will you say have the maximum accuracy in terms of positivity? And then my next question is, we were talking about if you see a beautiful girl or a beautiful guy you want to marry, and then he or she told you that, hey, I'm sorry, Doc, I have HIV and AIDS, what will you do? So if the patient say yes, I mean, the future partner say yes, I have HIV and AIDS, I'm on my drugs, you think how long, if a patient starts his antiretroviral drugs, how long does it take for the patient virus load to be undetected? Then I can have the confidence, okay, now we can have some sex to have our children. Because you don't want to marry and keep having protected sex, then one of the essence of marriage is to produce. So how long will my partner be on the drugs before I'm convinced that that virus load is low and we can take some chances to have children? Thank you very much.
Yeah, so first of all, I want to say thank you to the senior colleague, Jonathan. Yeah, long time. Yeah, thank you for those questions. So I will take the last one first. So yeah, from research, evidence-based, it would take so long the HIV positive person is on the ARV, especially TLD, it takes up to at least 6 months for that viral load to be, go down, like how we say, undetected. So from 6 months above, that time we can, be confident to say the person viral load has, at least dropped. But notwithstanding, if this person was at the stage of getting what we call the AIDS, that is another different scenario. So you will have to check the viral load continuously until you can detect, or until you cannot detect, that virus within the blood of the person. So yeah, but on the normal situation wherein the person, does not have any opportunistic infection or hasn't reached to that point where you call AIDS, in a period of 6 months above, rarely you can see that the viral load can automatically drop, and it might lead to certain situation where you're not even detecting the virus within the depression. So it's safe to say that above months up, you can be having an undetected viral load in your body. Okay, that's it. So the next question was the test, right? Looking at the sensitivity and the specificity of the test. So like you already put it, we had the first to the fourth generation. So we know that most of the new self-tests or the self-kits or the point of care kits that are used mostly are the fourth generation nowadays, because the WHO new guideline came up to say that's what Liberian is following. Like, you have to do what we call the trade test. We stay, subscribing to the trade test where I talk about the determine, the bowel line, and the unit goal. So sometimes, for instance, let's say we're talking about false positive and false negative. So we know that when you say false positive is where actually the person does the test, and then the test is positive, but then the person does not have the virus within them. That's what we call false positive. And on the other hand, when we say false negative, is the opposite of what we just said. So if, for instance, a person comes to the hospital and does the HIV test, maybe using let's say the determine, because the rapid test, like we say, is part of the fourth generation. And most of these things, let me just go back a little bit. They can be able to detect what we call the immunoglobulin, whether G, and M. They are very keen in detecting those immunoglobulin. And they can also be able to determine what we call the viral protein. Normally, it's called the P24 antigen that is on the viral, the HIV virus. So those things are very specific and sensitive in detecting those antigen and the antibody. All right, so most of the fourth generation, so it's encouraged that they use the fourth generation. Like I said, most of the tests that's coming, that are coming now, they are formulated after the assays used is the fourth generation. So in Liberia, for instance, we use the determine and the bowel line. The bowel line usually used to be for detecting the types of HIV. We have HIV-1, HIV-2, but we just try to overlook that just to at least give credence to the diagnosis, number one, and to be sure that we not giving a false positive to this patient, because like I said, it's a lifelong thing. It's a chronic disease. So if you say Tagli has HIV, we know the mental implication it has and all stress, that it brings. So it's good to at least authenticate evidence-based to know that the tests are actually is positive before you diagnose the patient and the patient start their medication. So for Liberia, like I said, we usually determine the bowel line, at least the unit go sometimes is the tiebreaker. So sometimes you see that the patient will come, determine, will show positive, and the the bowel line will show negative. So we use the unit go now as a tiebreaker to say, okay, let's see whether the patient really have HIV. And if it comes up positive, then it means that that patient is positive. And another thing, like I said, most of the time, these tests are very sensitive and specific, almost combined. Looking at the specificity and the sensitivity. They almost reach to 99%. So I go back to some of the time you will see arrests cases wherein you have a false positive. Let's say somebody just got infected with this HIV virus. All right, we have a period called window period. Sometimes, like maybe I just got infected within less than 6 weeks. All right, and then you go to do one of these tests. The likelihood that you will not find the antigen or the antibody might be very high. It might be that I'm already in that period that I will get infected, but the test showed that I don't have the virus, because at that time the virus is still trying to replicate. All right, it hasn't reached that threshold to say, okay, it can be detected by the test done. So some of those instances, sometimes you can have false negative results in those instances. All right, and so sometimes the usage of the test as well. Some people but I know that people are trained to use the test. So sometimes the use of the test, you have to use it properly and wait to the allocated time. We said in 20 to 30 minutes, most of those rapid tests will give you answers. So you want to take this proper specimen and put it follow the direction and put a buffer or the reagent, in the right way to be able to get like these two lines that will say, oh, it's positive in those test strips. So these are some of the things that that people need to be aware of. But yeah, so the tests are very specific and sensitive, as it relates to detecting, the disease. So sensitivity, it means that if the patient has this test, the virus, it will definitely show that the patient has it. You know, if the patient does not have it, it's specific to show that the patient does not have the virus. So, yes. Yeah.
Thank you. I hope that that question was addressed, Dr. Hart. So we're gonna take Dr. James Sonkari. Are you there?
I think there's a follow-up. There's a follow-up, Dr. Bala.
Okay,
There's
yeah, sure. You can come with a follow-up.
Yeah, just there is no senior colleague this person. Just yesterday we're discussing and learned that there is a combined test now that detect both the antibody and antigen. And I learned that the antigen is the P24 is early detected. So do we have that test in Liberia now that we can just use the one test, combined test, to be able to have a sensitivity of 100% in Liberia?
Yeah, so now, like we say, the fourth generation, like I just said, all right, those tests are very specific. They get detected, you know, but at least it should be above 10 days onward when you get infected. But less than 10 days, you might not get this. Oh, in Liberia, yeah, we do have the, yeah, we do have it. We stay using the Unigo. It's a Unigo. We have it in Liberia. Yeah.
Okay. So James Sonkale, are you there? You can unmute yourself. We can hear you well, Dr. Uyami. I'm not sure. I'm sorry. We can hear James Sonkale loud. James, maybe you need to check your microphone. We can hear you very clear. Okay, so what James is trying to come through, is there any other, I don't see another question. I don't see another hands up yet. Is there any other question? Mr. Sonkale, we can get you very clear. Maybe you could type the question in the chat room. Okay, so while we're trying to get the question from James Sonkale.
Hello, are you hearing me now? I hope you are hearing me.
Yes, you are true, Mr. Sonkale, go ahead.
Oh, okay. Are you still hearing me?
Yes, please go ahead.
Okay, I think I have two questions.
Okay.
The first one is, I want to know the probable risk factors involved in contracting HIV and AIDS. Then my number 2 question was answered by Dr. Tegley, but I think I can rephrase it. He was talking about false positive and false negative. You know, from my background in computer science, it's a computerized terminology. When it comes to false positive and false negative, I have experienced that at the hospital before. I can remember 2014 when I first came to China, I think 2013. My passport expired. I decided to go at the hospital to renew my visa. But after carrying on the test, there was different disease name given to me that I didn't have at the time. So I challenged the result at the hospital. When the Chinese gave me the result, I challenged the result. I have to go to another hospital, and they told me that I didn't have that disease. And I went back to that same hospital and did the same test, and there was nothing of that kind that I had at the time. So in that process, they have to call me, the doctors have to call me on an emergency to beg me, you know. So and one of the things I want to say about this false positive and false negative is about the machines they are using. You know, sometimes at the hospital, the machine they are using from a computer science background, sometimes it can be faulty, right? Because they are using programming language to code the machines. So looking at the timing, right? Maybe the machine was produced for maybe 5 years and they have used the machine for over 10 years. So definitely the machine, the result from that machine, the performance level will be poor. So sometimes you maybe as a doctor at a hospital, you have to be very careful as to how you come up with your result when it comes to testing. Yeah. So yeah, that was serious problem at the hospital at the time, and they were asking me that they want to pay all the bills. The other places I went to do the test, they will be responsible for that, and they were asking me to forget about everything that happened. The head doctor had to call me in the office for counseling and all of that. So the false positive and false negative issue is very important. So I was listening to some of you about counseling. Counseling is very important because sometimes the result given by the machine cannot be accurate. So you had to look at it very keenly. If you were giving maybe test result without going through proper investigation to know as to whether that result is actually the right result, at the end of the day, you will put that patient at risk. So thank you very much. So my follow-up question to that is, in that process, in regard to this false positive and false negative, from the doctor perspective, what advice can you give to your patients or some of us who are not directly into the medical field? How can you encourage us when it comes to such problem or maybe situations? Maybe it might happen to another person besides me now, because for me, I'm just giving my experience with respect to what I have gone through over the years. So what would be your advice as a doctor? Thank you.
Yes, thank you so much, James Sonkali, for your questions. So, and I would like to say it's unfortunate that you had to go through that, and it's not just unique to you. There are other people who really, suffer same situation, but it's not a good practice. Yeah, so that's why, like I said earlier on, the WHO, they give standards or guidelines based on evidence-based practices that people adopt and follow. So, for Liberia now, because of, we have some cases like that, there are ongoing cases like that, but because of those kind of, situations that happened before, we are trying to at least do 3 tests before we can come out to say, okay, you're positive. And even that time, sometimes we would that the test should be repeated, for example, in another 3 months. Because what we have, we call it, we got something we call the window period. We got something they call the window period. So if I just got infected and you did my test, probably sometimes I may not have the viral load for you to for the test to detect it. I might be positive, but when you do the test, it might show a false negative. So for example, I was exposed to somebody, or maybe my mind is telling me, oh, I had some unprotected sex with somebody, and my mind is telling me, that, you need to do your test. And after that test, after maybe 5-7 days, and I go straight to do a test, and you tell me, oh, Dr. Teddy, your test is negative, and just go ahead. So, but nowadays, we are encouraging people that they should do their test after at least 3 months or within a period of 3 months, because we got a window period. In that window period, sometimes, like I said, the virus is trying to replicate, and the body too is fighting against this virus, the foreign invader, which is the HIV virus. So during that time, sometimes when you do a test, it might read false negative, but you have the disease. So you wait up to that time, maybe 3 months after, and then you do the test. So when you do the test again, even for Liberia's situation or scenario, you have 3 tests. In that same day, we can do 3 tests for you. That same day, using the various tests I just named, they determine the bowel line and the unigo. So with those things coming back to say, okay, all of them, 3 of them saying positive, then surely you are positive. But you were told before you are not net positive because you're in your window period. All right. So those scenarios do occur. So another thing is that it's good as it relates to mental health, social counseling. All of us here who travel outside Liberia, even went to China. I can remember during 2010 when I was living in this country. Me and other doctors, other non-doctors, but before then, just graduated, going to med school, and I could imagine, I was called in to do this HIV test, and I was canceled. And then during the counseling period, there are a lot of things they show you, that they say to you just to reassure you, but those things, mentally, we are humans, all right? So, but I was so afraid, and later on when I got the result, then I was like relieved. But it's good to really counsel the patient, put the patient in the right position, counsel them before doing the test. And there's a normal practice that occur. That's the standardized practice. That's what should be, practice all around the world. And that's what we try to, subscribe to. So that's something that we can do. We're supposed to do before you even offer test. Although some situation or in some instances, people do the test. I've been telling, the patient, but it based on the discretion of the doctors. And later on, they will stay, even if it is positive, they will still recommend that you go to the section on HIV and AIDS where you will be counseling, and then you repeat the test. So those things happen. So, and like I said, we do the 3 tests. It's good that we do the 3 tests to really ensure that you have the disease. That's number 1. And then, so when it comes to the faultiness of the result, sometimes, like I said, maybe the test kit probably might be faulty. All right. So it do occur that the test kit might be faulty. The test kit that you used to do the test, okay, or the person that doing the test is not that okron or is not skilled at doing that test. that might lead to another false positive, all right? Or sometimes the reagent we use as well, maybe it's a spire or something else, but eventually trained HIV specialists, those are things that look at. The first thing you take, you look at the expiry date, and you open it, that procedure because they've been doing it over. But we're not saying that the mistakes cannot be occurred along the way, but those things are prone to errors as well. So, and that's for that. So really come again. As it relates to the second question, I mean, the first one asks, you're talking about risk factors or risky behaviors. That's how we call it. So basically, we have other behaviors that that people engage in can have the disease. Like we said, HIV can be transmitted through bodily fluid. We name them. We say semen. All right. We say vaginal and anal discharges, or blood through blood medium. All right. So basically, if you have an unprotected an unprotected sex with somebody, whether through the anus or the vagina, and that person has the disease, you could get the disease from the patient as well, or the person, not the patient, but the person. Or if you're already having other STIs, sexually transmitted infections like gonorrhea, you're having herpes or chlamydia, or bacterial vaginosis. These are ways that probably if the person is already, I mean, if you infected as a man and the woman is not infected, having those, I mean, having the intercourse with them unprotected, and you discharge in them because they the mucosal membrane of the vagina is already fragile, it's already broken. It's easy that the HIV virus can burrow through the mucosal lining of the vagina and just go and sit in and then start to attack the immune system and replicate and infect that person. So there are other ways, that's another way. Another way is sharing needles or sharp utensils. And this is from tattoo provider, people who give tattoo in the tattoo shop, to people who can weave hair, to the clinician in the hospital who providing care or using sharp utensils or needles. And that's why we have certain preventive or precautionary methods in the hospital that don't use sharp and just dispose of it. You should have a sharp box at least near you for every procedures done, and you should not recap the sharp use or needle use. If you properly dispose of these sharp materials. So we have, what we call the preventive measures in the hospital that medical doctors or health practitioners usually encouraged to follow. So, but those are ways that you could get it to. Or through transfusion. Okay, my brother is sick and then they want me to, give him blood. I come and sometimes you don't do the profiling to check whether Teddy has HIV or not. And you get him my blood, and just give it. Maybe you get one test and check this in his window period, but he still have the virus in him. So he gave him blood to his brother. So definitely, why is from Teddy we want go to his brother. So that viral although you did a test, 30 days in his window primary, you just got infected recently, you don't know. So you can give that disease to your brother through blood, blood transfusion. Another thing is we now have in a Liberia, like we talk about risk groups, you know, in a population. We're seeing lately a lot of people in our country using injectable drug. All right, they are injecting themselves, and you know those things. You know they're using the same syringe from person A, John Brown, Peter Paul, and the next person. So you inject your drugs, you pass it on, and the person inject it and just go along like that. So through that medium, you can be able to get the disease as well. So even through piercing or cutting, what we call female genital mutilation, those things also, all right, using the same razor blade to cut the clitoris of a, of a female and using it on another person, that could also help to transmit the disease if somebody has it to another person, or through stick injuries, even in the workplace. All right, maybe somebody used something in maybe or something and caught themselves, or sharpened utensils in the workplace even, and then you use the same thing and you caught yourself, and the virus active there, so you could also infect yourself through that medium. So these are ways that you can get the infection. And I would like to say this: in Liberia right now, the highest HIV prevalence is amongst what we're seeing from the study is among male who has sex with male, MSM, male who has, or male who has sex with male, and also female sex workers. So these are the two groups that have the higher prevalent rate amongst them for HIV infection in Liberia. Yeah. I hope I answer your question.
Thank you so much. Thank you so much, Dr. Tuckley, and thank you. So
yes. Hello, Doc.
Follow up.
Yeah, just lastly, I just want to say something. That's all. Yeah, lastly,
give you 10
yeah.
seconds.
Okay, what brought the urgency about calling me back to counsel me was it's about the same false positive. The patient that was giving my result was prematurely discharged without giving the actual result to the patient. So when the patient went home, the patient came back with the entire family to challenge the hospital, saying that because the patient said, I'm still sick. Why should you give me this kind of result? And there's no improvement in my health status. So at the end of the day, after the carry investigation and look at their record, right? When they look at the entire dossier, at the end of the day, the result was for me. So the result they give to the patient was not the actual result for the patient. They were prematurely giving. So they have to ask me, to pardon them in the process, not to tell anybody. And since that time, just today, because of this program that I'm trying to share with you people, the country we are in, when they tell you don't do this, if you do that, then you will be challenged one way or the other negatively. Yes. So that's what happened. Yeah. So that's what happened. I just decided to share with you. So the patient challenged the hospital, and the patient went there with a whole group of people to challenge the hospital that that result was not for him. So they have to check their medical history, and they saw my name that everything was excellent. And at the end of the day, they have to call the both parties together. The patient said, I don't have problem with that. The father of the matter, I was giving wrong information. So come and heal me. Come and give my treatment. I don't want to go home. So thank you very much for this program. At least I was able to share this with you today. It says I was told not to tell anyone for the sake of education.
Thank you so much.
Yeah, thank you.
Sankale, for for sharing that experience. And I think young doctors on the platform, medical students and nurses, that's just a lesson because it's a teamwork. I think sometimes we can be very irresponsible. Sometimes we can be diligent with our work. And maybe me say I'm a medical student now, I don't really care. So that, attitude goes to clinical practice, there where those kind of things come from. And I think that's just a lesson we can learn from Mr. Sonkale's story, how we need to be diligent and responsible in our work, because you could just mess up somebody's life with, non-commitment attitude, right? Because now maybe you think you're a medical student, young doctor, you don't really care, but it could cause just somebody's life and sometimes even your own life. So as medical professionals, we require diligence, commitment, and a lot more. So thank you for sharing that story with us, Mr. Sonkale. So we intended that this program going to be 1 hour 45 minutes, but we've gone extra 15 minutes, so we have to now end here. So I'm just going to allow my panelists to give a parting word. So, Madam Pauline Johnson, is there anything you want to say in a few seconds as your parting statement before we close?
Okay, I just want to say thank you and for the opportunity to come on the platform to be able to share with people that the pressing issue that we are faced with health and our health delivery system. So I just want that I urge we all that we will be able to work in hands in order for better health, in order for our mental well-being and what have you. So thank you so much. It's an honor again to attend the program.
So, Madam Joel Johnson, your parting words in few seconds. Do we still have Joel Johnson on the platform?
I'm sorry, I muted my mic and I didn't even know. I just wanted to say I appreciate, every one of us for coming on this platform to have this discussion. HIV is a highly sensitive topic, especially in our society. And I really learned a lot from each and every one of us, especially Dr. Tegley. Like, he elaborated on many things so well. So, I mean, moving forward, we should continue to spread the word on HIV, in every way that we can, in the hospital, in the community, in our homes, and just continue doing what we're doing. Thank you to everyone.
Thank you. So, Dr. Tegley, thank you so much for the deliberation. Your parting words in 2 seconds.
Yeah, so I'm grateful for this opportunity that I have to come on, and join you guys also to share on HIV and AIDS. I think, like Joel was saying, is a really a topic that we don't need to shy away from. We need to really be ambassadors. Like anybody can, especially in the medical field, like we medical practitioners. We need to go with this certain level of public health. So we need to be ambassadors out there, propagating this message that HIV is real, but it's not a death sentence. When you get it, you need to be consistent with your medication. And also, we need to also help these people who have HIV and AIDS, because there are a lot of people still having what we call denials of the HIV and AIDS. And they are the ones that we really see having those terminal diseases, like those opportunistic infections, and coming down with a severe disease and dying. But most of the people have interacted, rubbed shoulder with people, even in school, in the workplace, who have HIV and AIDS, HIV, but they are very consistent on their medication, and they have all the support that they have. So it's good that we also, create this robust awareness out there to the public. And I really appreciate this platform. I hope that we can also dive into
Thank you. So, Dr. Dean Naomi Flomo, my co-host, do you want to say a few things in a few seconds before we get going?
I just want to say thank you to our speakers for today's program. It was really amazing having you on and to educate us on things that, some of us didn't know. I really appreciate it, and thank you for taking out your time to be here.
So thank you so much to all of you. It's been an honor having you, and thank you for this wonderful discussion. We tend to talk about things that people don't want to talk about, but we hope that we can be able to contribute our little, in a little way, possible to humanity and to our community. So thank you for joining us tonight. We want to encourage you to follow our different page. This program, this 8th edition, going to be broadcast 2 hours later from now on our different channel. And so you can follow that on our Facebook page, on YouTube, and on Twitter, and hopefully Instagram. We're going to be going live later with this. So you can follow that again, ask many other questions, and in the chat room there. And I believe we'll get people in the chat room to respond to you. So thank you so much for joining today, and it has been an honor having you. So I just share my screen showing the different, the address of the different platforms that will be broadcasting this show 2 hours later. So you can follow the Facebook page, the Facebook group, and the Instagram page, and also the Twitter page. So thank you for joining us, and we want to appreciate you and say I'll see you in our during our 9th edition, and we hope that we can have another wonderful time today. Thank you for joining us, and see you.
Bye. Stay safe. Get vaccinated.
Bye. Thank you.
Hey, Jigger.
Thank you.
Yeah, man.
Yeah.
Thank you.
Thank you.